Hello and welcome to the EMJ Podcast with me, your host, Dr. Jonathan Sackier. Today, I'm joined by Dr. Rachel Rubin, a board-certified urologist and sexual medicine specialist and assistant clinical professor at the Department of Urology at Medstar Georgetown University in Washington, D.C. I used to live and work just across the way at the competition, George Washington University. Lovely, lovely city for those who haven't visited. So Dr. Rubin is a clinician, researcher, and very passionate educator. Having completed her medical education at Tufts University, she then completed her urology training at Georgetown and her sexual medicine fellowship with Dr. Irwin Goldstein in San Diego, another place I lived and a gorgeous part of the United States. Early in her medical training, Dr. Rubin recognized the limitations of the current healthcare system. And in a 15-minute visit, she couldn't even hear her patient's entire story, let alone have a conversation that allowed her and the patient to come up with a care plan based on the patient's needs and goals. As a result, she launched her own practice in 2022 so that she could provide the kind of patient-centered care with a multidisciplinary approach that she wanted, working closely with physical therapists, sex therapists, and other medical and behavioral health providers. And I think you'll get a kind of a hint about this fascinating lady whose last name is, as I said, Rubin, when I tell you that her daughter's name is Billy. And I'm sure she can tell us about that. So welcome to the podcast, Dr. Rachel Rubin. Real pleasure and honor to have you here.
Wow, thank you. What an introduction. Thank you for having me.
Oh, it's so first of all, you're going to tell us about Billy.
So I believe that everyone should torture their children as soon as they're born. And, having my last name be Rubin, and I knew my kids' middle names was gonna be Rubin, I decided that Billy Rubin would be too funny not to call her. And so, we actually reverse engineered it and said, what nickname for a girl, Billy, can we do? And we found Sybil. But everyone calls her Billy. She is Billy Rubin, and her levels when she was born in the NICU were a little elevated, but not enough for the lights. But it's good cocktail chatter for sure. We're very weird people.
It truly is, and I've got a collection of names, and we could probably trade them off, and we'll have a private conversation. But I've got some people I worked with over the years, or had patients with names that forced you to bite your lip. But that's priceless. I love it, Rachel. So diving straight in, you've emphasized the importance of patient-centered care, which I mentioned. It's always struck me when I hear this, it should be obvious. That's what we are. We look after patients. Why do we even need to have this conversation? But tell us about the key principles behind this approach and how it transforms the patient experience in your specialty of sexual medicine.
You know what's so insane is that in 2022, the New York Times wrote an article, full page of the science section, and it was called "Half the World Has a Clitoris. Why Don't Doctors Study It?" And they didn't want to run the article. They said, oh, this isn't interesting to our readers. We don't want to run this. It took about 9 months for that article, beautiful article written by an amazing journalist named Rachel Gross. And in that article, they talked about how I take my female patients, I give them a hand mirror, and I teach them about their own genitals. I say this as I'm examining them. I say, this is your labia majora, this is your labia minora, this is your clitoris, this is the urethra where you pee through. I go through the whole thing, and I educate them. And the craziest part is that was innovative science in 2022. Yeah. When that article landed, it went like wildfire. It was the most shared article of the entire year, one of the most shared articles. And it is simple. It's so simple. And yet, why do we put a sheet up and examine patients like we're mechanics and that they shouldn't see their own body parts? And so for the spending time with people, getting to know them, it's simple and obvious. And yet the medical system is designed to do just the opposite. But I'll tell you, all of my patients, no matter what age, they have such rich, incredible stories. They have whole lives. They have so much more to teach me than I could ever teach them. And I refuse to think that I know everything about their bodies or what they're going through by spending only 10 minutes with them. It doesn't work. And when you're dealing with sexual problems, it's biopsychosocial. You got to really get to know people and what it is that they care about.
Yeah, absolutely. Music to my ears. And back in the days when I trained, it predated a lot of the technology that we have now. And we were told that start with the history, start with the history, start with the history. And as I've taught residents over the years, and they stand at the end of the bed, barely looking at, let alone touching the patient, and then we're going to order this. And I said, well, how's about you actually talk to the patient and actually learn something about them? And, I always like to say that there's the disease and there's the dis-ease, right? There's the concern that comes because they've had a heart attack or whatever. And in fact, one of my a memory is of a patient who had a colon cancer and who got it into his head that he wasn't going to be able to have sex anymore. And it was like, how did that happen? Well, it turns out that that's in some of the lay literature. So, I talked to my urology colleagues and said, why don't we set up a program and actually try and re-educate patients? So I want to dig into this. In your practice, you collaborate with physical therapists, sex therapists, and other specialists, as I said. How does that work? How does a multidisciplinary approach work and improve outcomes for patients with sexual health concerns? And how do you what's the cadence of your introductions to other specialists?
Absolutely. I joke that I'm a little bit of a psycho-urologist in that I actually talk to patients and spend time with them, so everyone assumes I'm a therapist, which is outrageous in and of itself. What I always tell patients that I am not a magician, but my batting average is so good. And the reason my batting average is good is because I meet people where they are and I give them what they need. And by really spending time on that history, you nailed it there, is that when you dive into the deep details of the history, and then you can synthesize that history, not letting AI synthesize it, but you use your own brain to synthesize it and say, wait a minute, what I'm hearing is this may play a role, this may play a role. There may be a psychosocial component, there may be a musculoskeletal component, there may be a hormone component, an anatomy component. Let's talk about it. Let me explain it to you. And here's the menu that I have. And that menu often, or toolbox, you can say, often looks like, hey, I really think you should work with this particular sex therapist who I know very well and I can connect you with. Or, hey, you live in this part of town. This physical therapist is top notch, really incredible, and can really help you. And again, we sprinkle it in. Not every patient needs the same thing. And what I will tell you in my years of doing this, the magic happens in the team. The magic happens when there is a team approach where a patient feels taken care of, they feel seen, they feel validated, they feel like someone is helping and caring for them and with them, and they actually feel empowered to make the decisions on their own of like, oh, that makes sense to me. And then this compliance thing, this whole non-compliant patient BS that we always talk about, it's when a patient understands why they're doing something, they always comply. They do it. They want what's best for them.
Yeah. Well, I think you see it in consumer goods where I forget which brand it is, and they say, my best customer is a well-informed customer. It's absolutely the same thing. I remember my dad asking me, why the hell do I have to take these pills? I don't feel ill. And I sat down and explained, well, you got high blood pressure, and this is what's going to happen if you don't take the pills. And it's like, oh, why didn't he tell me that?
And back to sexual medicine for a second, because I think if doctors were more competent and confident in discussing sex, because sex is something everybody has or wants to have in some capacity, either with themselves or with a partner. And if we can relate medicine and medical things to sexual health, because the high blood pressure is going to affect the erections, It's going to affect the orgasm, it's going to affect lubrication. And if we can explain that to people, we can actually help them stay following their medications and their different plans.
I would challenge you and say it goes beyond the medical profession, Rachel, because let's go back 10, 15, 20 years. We've never met in person. I'm a bloke, you're a woman. We're talking about sex and clitorises and orgasms. That would not be socially acceptable, even in medicine. Not that long ago. Don't we need to democratize and just say, hey, listen, you get restaurant reviews, right? You can look at the menu of restaurants around the world. Pornography is this sort of nasty, dark little corner of the internet. Why isn't sex discussed in a more liberal fashion, like it seems you do?
Well, it's a huge problem. They don't even teach us the anatomy. It's not really discussed in medical school. And so then the question becomes, who is responsible? Who is responsible for teaching people about their sexual health? Is it your middle school gym teacher? That's how I learned it. Is it not well? Is it your friends? Is it your first partner in high school who's supposed to know all of your buttons and what you like? Because I tell you, that certainly isn't going to. I teach a high school sex ed, and it's not working out that way. And so who's responsible? If it's your doctor, well, we're not teaching any. We've published on this. We are not teaching any kind of standardized curriculum when it comes to sexual health and sexual dysfunction, especially on the female side of the equation.
Yeah.
And so we are in trouble because pornography then becomes the teacher, which is like learning how to wrestle by watching the WWF.
Well, I would suggest it's like learning how to wrestle by watching motor car racing. It's got nothing to do with reality. Actually, I'll tell you just a quick aside. I got a phone call recently from a journalist in London who was doing a bit of investigative journalism about a chap in Los Angeles who, quote, claims to be able to teach women how to have orgasms. And, based on what she told me, it really didn't seem very reasonable. Actually, it seemed very unfair and very unpleasant. And she was asking me questions about it. I was saying, look, we ought to be having these discussions. And for me, I've published in some bespoke medical journals, but now I'm published in the Daily Mail online, which I'm very proud of personally. But yeah, we need to be talking about it. And I think you're the lady to do it. So as an educator and someone who's advocated for better training in sexual medicine, what gaps do you see in current medical education? You mentioned anatomy isn't taught. It was in my medical school. We did 18 months of anatomy and included, obviously, the female perineum in great detail. But what gaps are there? How can healthcare providers better equip themselves to address sexual health?
Well, this is a challenge that I'm not sure I know the exact answer for, because if you ask me to analyze an EKG, if your life depended on it, I would not trust me to analyze that EKG. And you could argue that the heart trumps genitals and is a very important organ. And so what we teach medical students, so much is forgotten, right? So much when you specialize, so much is forgotten. And we learn how to learn. So if I could probably learn pretty quickly how to read an EKG again, but it's been years and years, right? So the challenge becomes, when are we supposed to learn it? And who is responsible for making it a part of their regular practice? Because I would argue we are at a crossroads of sort of a disaster, because we have decided that menopause medicine is a tiny little niche of women's health in sort of gynecology, and that misses the point that this affects the bones, it affects the brains, it affects the heart, it affects everything. And so by not teaching doctors who look at bones and brains and hearts about anything that has to do with menopause, we're in trouble. And that's sort of how we teach nothing about menopause in medical school and residency. And so when it comes to anatomy, right, when I was in medical school, now quite a number of years ago, you learn how to do a pelvic exam. And they say, oh, don't touch the clitoris as not to make the patient uncomfortable. There's no standardization of vulvar exams, for example. So we don't teach medical students how to evaluate the labia or the clitoris or the hood of the clitoris, the prepuce of the clitoris, which our research shows can get adhesions 23% of the time in all comers. And so by not teaching medical students this, we don't ask about, like when I went to med school, it was, when you did your history, it was, do you smoke? Do you drink? Do you do drugs? Do you have sex? Men, women, or both? Like it was a vice, right? Sex was a bad thing, like heroin. Do you smoke? Do you drink? Do you do drugs? Do you have sex? So we're not asking about libido. We're not asking about orgasm. We're not asking about erections or arousal. Now, as a urologist, I ask about erections. I ask about orgasm because we are trained to do that when it comes to quality of life measures for our male patients. Our gynecology colleagues, God bless you, you are asked to do way too much with way too little. It doesn't come up. The word clitoris is not anywhere in the American standardized learning objectives for OBGYNs. The word doesn't even exist. Can you imagine if the word
No,
penis...
I can't imagine that. That's baffling.
It's not on the list. It just doesn't even make it to the list because there are so many more important things that OBGYNs are responsible. Women are dying in childbirth every freaking minute, so it's so bad. And we are putting this whole entire, so the anatomy is bad. Our ability to talk about is bad because you have the blind leading the blind. If you don't have anyone at your institution who can talk about this, and there are a handful of amazing people, if you are lucky enough to have them at your institution, you learn well. They can leave, they can retire, they can go away. And if we don't have trainings, if we're not training the next generation, we're hosed.
Interesting. So you need to get out there more clearly because you're such a great communicator about this, and hopefully this podcast will help. So I've mentioned stigmatization of sex in clinical settings, or you've mentioned in clinical settings and in many cultures, of course. What strategies can you suggest to our audience listening who are not specialists in sexual medicine? But one thing is for sure, and I'm harking back. You're triggering all sorts of interesting memories. Having a conversation on a panel about why we don't talk about such things. I was on a panel. It was at the American College of Surgeons, and I said, "Put up your hands if you've had sex in the past year." And there was hesitation. I said, "Oh, come on, people." And of course, pretty much every hand goes up. I said, "So why aren't we talking about this?" So what strategies are there that you can recommend for healthcare professionals to create a safe and open environment for a patient to tell them, this is my problem, and then that doctor can then refer them to someone like you? And again, destigmatizing what is perfectly normal human behavior such that people can enjoy a satisfying and rewarding sex life.
I think it's so important that we remove it from the vice section of the social history.
It's, by the way, when we trained, it wasn't.
Oh, so that changed. So I'd be curious when that all changed. And so again, a review of systems is somewhat of a dying art these
Yeah.
days. But there's something about thinking of it more in the terms of review of systems as you're really knowing about the patient. And I think for us, the most important thing is, what does your patient care about? Because if you have someone with colon cancer who deeply cares about his sexual health, well, that's important to him, in which case it needs to be talked about, especially before you do a surgery and mess up his nerves and his pelvis, because there are dire consequences. And so informed consent, talking about sex when you're going to give a medicine or do a surgery, is so important, because nothing is worse than a pill or a surgery destroying a sexual life. And they are mad. Patients are mad. But if you say before, hey, you've got this big giant cancer, we have to do this, here are the consequences, which may include X, Y, and Z, then the patient comes back and says, doc, I know you did the best that you could. I'm disappointed. I miss this part, but you did warn me. And so let's get this taken care of. And we see this a lot when it comes to prostate cancer, with any pelvic cancers, with gynecologic cancers, or surgeries. We see this a lot. So I think just asking about it, talking about it. And again, just like my whole thing is, we should be talking about sex like it's high blood pressure and diabetes, because it is. High blood pressure and diabetes can affect sexual health. The genitals are muscles, nerves, and arteries. That's what they are. They are not magic. They are network. They're biology. They're physiology. And they happen to be physiology that brings us connection and warmth and pleasure and closeness to partners, which is so missing right now, right? There is a loneliness going on. There is a lack of connection, a lack of communication, and a lack of touch that is really going on in our very frustrated society right now. So I think doctors play a really important role, but I can't blame doctors. Y'all only have 10 minutes. How are you going to do any of this in 10 minutes? How are you going to build a doctor-patient relationship? I mean, think of everyone listening, and bless you for listening to this. Has a doctor ever asked you about your sexual health? Like, really asked you? Because I am a sex doctor and I have never been asked, and everybody knows what I do for a living because I never stop talking about it, but no one has ever engaged me in a deep, connected medical conversation at all. And I think we're missing that high touch point, that ability to connect deeply. And I think that's a cure for burnout in a lot of ways, because what fuels me, what fills my cup, is just deeply connecting with my patients and knowing their highs and their lows, and knowing more about them.
Yeah, I'm a few years back, a very good friend of mine, lovely fellow, very nervous guy, was diagnosed with prostate cancer. And he asked if I would go to the appointment with the urologist. And it was a prominent urologist at a prominent institution. I obviously won't name names. And the guy was recommending a radical prostatectomy to my friend. And he basically minimized the risks of incontinence and impotence. My friend had recently got married for the second time to an amazing woman, and he very freely discusses sex, very freely. Men don't normally talk about it between our peer group, but he is very happy to. And he asked me afterwards, were those numbers correct? And I said, the literature doesn't bear that out. The literature doesn't bear that out. And he ended up choosing to go a different route and preserve his sex life. And thankfully, I think he's now 6 years on and disease-free. But we need to be honest about those risks, right? Not minimize them.
I think the challenge, we see this, right? This is a huge problem in my field of urology because we don't want you to die of cancer, of course, and the minimization of the collateral damage of cancer treatment. And I wish that everybody could have a conversation with a sexual medicine doctor like myself or my colleagues before they make decisions and after, and to have you as not the cancer doctor, but the quality of life doctor that's there with you every step of the way. And again, it has to do with informed consent. But when you get informed consent for a surgery, they say, well, you could have a stroke, a blood clot, a heart attack, you could die on the table. Well, if those things were likely to happen, you would never have surgery. So the problem is they're very small risks, but they are risks. The doctors, they get their spiel. So they just have their rote spiel that they do. So, well, you could die of a blood clot, heart attack, you could die on the table, you could have a stroke, you could get incontinence, you could get impotent, erectile dysfunction. Those get heard the same level as you could die on the table. And so the problem is no, these men hearing this, they've never had incontinence. They've never had many erectile dysfunction, and they can't even imagine what a stroke would feel like, what incontinence would feel like, what erectile dysfunction. So they put it in that bucket of like, yeah, that's going to happen to that other guy, but that's not going to happen to me. But it's a very real, a side effect of these surgeries.
Well, here's a suggestion for you. Dr. Rachel Rubin, you need to build a cadre of colleagues in your specialty and get this mandated as one of the steps that patients... Look, breast cancer patients are entitled to meet a surgical, a medical, and a radiation oncologist and hear from all three. And I think as a bloke, people need to be having a conversation with someone with your qualifications before making a decision. I think that would be a brilliant goal. Get a petition going.
The challenge is our medical system does not value quality of life and sexual health, and they won't pay for it.
Ours does over here. Let's have a...
You guys have so so many things that are better than we have over here.
I have to tell you, not everything.
Not everything.
In America half my career. There's some wonderful things in American medicine, but there's some wonderful things here as well. Let's talk. So I want to go to something that you were quoted as saying, 2023, menopause has the worst PR campaign in the history of the universe because it's not just hot flashes and night sweats. It was a New York Times Magazine article. Digging deeper into this topic, and you've already mentioned that menopause, is not just, I don't need tampons anymore. It's bone health, cardiovascular health, mental health. There's so many things to consider. Is there an improved understanding of menopause amongst healthcare professionals and the general public in recent years, or is it still garbage and needs to be improved?
We are starting to have a moment, and actually, the British medical world is a little farther along on the sort of education advocacy than we are here. The menopause is having a moment, but it is important that we understand that there has been a complete lack of education to medical provide clinicians for many decades because of that Women's Health Initiative that came out in the early 2000s. And so you have a generation of doctors who, even if we can convince them that menopause is real, it's a thing, it affects more things, no one knows how to do it. Nobody knows that. It's one thing to say, oh, estrogen may be a good thing for you to try, but if your doctor doesn't know how to write the prescription, if your doctor doesn't know the difference between a patch and a gel and a ring and an oral medication, if your doctor doesn't know how to dose it, we're really not doing very well. And so again, we have a lot of work to do in this space. My big advocacy platform is vaginal estrogen, which is not even hormone replacement therapy. It's a low dose, localized. I think you all have it over the counter. I'm so jealous. But it's a vaginal estrogen product that can prevent urinary tract infections by more than half. Now, from a sex detective hat, vaginal estrogen is actually Viagra, if you think about it. What is Viagra? Well, it's a PDE5 inhibitor. It's a smooth muscle relaxer. It increases blood flow, helps with erections. And if you take Cialis every day, it can help with urination. Vaginal estrogen improves arousal, it improves orgasm, it improves lubrication, it prevents urinary tract infections by more than half, it fixes frequency and urgency, it can help with leakage. Holy crap, we have had female Viagra since the 1970s, since before Viagra came out in 1998. So we have a marketing problem. That's it. It's a marketing problem. Vaginal estrogen is so minuscule of a dose. It's such a micro dose. It doesn't go systemically. It does not considered HRT. You don't need to take it with progesterone if you have a uterus. And yet no one prescribes the damn thing. And no one does it because we think of this as a little vaginal dryness. Well, we published a paper last year that says if Medicare patients used vaginal estrogen, we could save Medicare up to $22 billion a year because of UTI visits, urgent care visits, hospitalizations for urosepsis. Urinary tract infections are killing women. They're killing women. They're killing your mothers, your sisters, your aunts, and vaginal estrogen can reduce it by more than half. We just published a couple of weeks ago that vaginal DHEA, this wonderful product Intrarosa, can also reduce urinary tract infections by more than half. And so there is not a single paper on earth that said it's going to have any risk to breast cancer mortality. There is no danger if you've had a history of blood clots. There's no danger if you've had migraine with aura. And so it's crazy because no one is using it, but we would save lives.
Well, we got to put some links to those pubs in the show notes. But have you done, other than the article I mentioned, do you talk about this stuff on TV?
I have a YouTube channel. We were on NPR about this topic. I've been screaming. We're screaming and yelling from every rooftop we can find because this is an international emergency, I would say, because the product is you could get a tube of estrogen cream over the counter in Britain, but $13 on some of the websites in America, Mark Cuban's Pharmacy or GoodRx, $13 for a tube of estrogen, which can last 2 months. So for less than $7 a month, we can save someone's life. And it's really, but here's the rub. That the box labeling that was put on in 2003 says that this product, which causes no harm, no damage, no paper on earth to show harm, the box says that it causes stroke, blood clots, probable dementia, breast cancer, and needs to be taken with progestin. Now, all of that is based on oral synthetic estrogen, one medicine, it is like saying a hydrocortisone cream is as dangerous as IV Solumedrol. It's insanity. So we actually met with the chief medical officer of the FDA. It was incredible. We were at a whole group of perimenopausal women in the room, and we presented all this data. We said, wait a minute, the box labeling shows this. Here's your Cmax. Here's your data. Here's what you said. This doesn't make any sense. And they sat there and they nodded and they said, well, industry really has to push through to get the box labeling off. Well, Pfizer, which has the only products that are still not generic, they just fired all of their women's health team. Who's going to do this? Who's going to take the box labeling off? Because it's false. It's actually, not only is it false, it's lying. The box labeling on vaginal estrogen is lying, which is actually costing our Medicare dollars $22 billion a year.
Jeez. That's pretty damn powerful. You mentioned rooftops. I've got another rooftop for you. Actually, I've got several rooftops for you. This is music to my ears. Rachel, I heard that I read that you're one of only a handful of physicians who are fellowship trained in both male and female sexual medicine. And I mentioned to you when we were chatting that when I was at Cedars-Sinai, there was a lady with your expertise who was a total hoot and utterly brilliant. Why do you think it's rare for sexual medicine training to encompass both males and females? And how do you think your unique background has helped you provide the highest quality care? I mean, I'll throw one thought out there. Wouldn't it be kind of nice if men actually knew what were, as you said, the buttons for women, and women knew what were the buttons for men? Because most partners in relationships don't talk to each other about this stuff. They say things like, I mean, I was very lucky. I had a psychologist who was one of my teachers, who said that, the most potent aphrodisiac is talk. Right? Actually talk to someone and never use the word "I don't like." You never met negative. You're always positive, and you always try to teach people how to talk to the members of the opposite sex. So yeah, have at it.
Well, we got a lot of work to do because we have to teach people to talk to each other in general. Partners, I find that people in couples, they know when their partner like how many macros their partner is eating. They know when their partner has constipation. They know when their partner is doing taking their blood pressure medicine. They don't know if their partner masturbates. They don't know if they've never asked their partner. I see so many women who come to see me, they say, I have low libido. And I say, okay, well, tell me what that means for you. And then I say, well, can you have an orgasm? Well, not with my partner, but I orgasm to fall asleep at night, or I have my own routine that I do, but their partner has no idea. And so do you not have a libido, or do you not know how to actually advocate for yourself in the bedroom? You ask about fellowship training. We have 27 fellowships for men's sexual health by the Sexual Medicine Society of North America. 27. Okay. We have one that is male and female. So one, that's my mentor, Irwin Goldstein's fellowship. We now, as of last year, there are two that just were created, one at GW, your alma mater, and one at Case Western that focus on women. So those are brand new, fresh fellowships, which is fabulous. Now, I would love to start a fellowship myself. That's kind of my next adventure of where my dreams are headed. But it has to do with funding and who will invest in this and who will actually help us get this forward. I have a whole research team of medical students where we just publish papers and they're from all over the country because, again, when I came out of my fellowship, multiple universities said, number one, what I do is weird. And number two, I won't make them enough money fast enough. Yeah. And you can't make it up. So I had to start my own place because my patients do deeply care about all these issues. When I can make a woman sleep again, when she can have, I had a woman, this happened this week. This woman came to see me. She said, Dr. Rubin, 25 years ago, I lost my orgasm. I used to have 3 powerful orgasms and they left 25 years ago when I started amitriptyline for migraines. She was in her late 30s. And she looked at me, she said, Dr. Rubin, they're back. They're back and I don't know why. I said, well, I know why. You started testosterone therapy 6 months ago. It takes about 5 to 6 months. And she was thrilled that 25 years she had not found her orgasms and they are back. So my patients deeply care about these issues, but the universities don't really care so much. So we need more fellowships. We also need to not force, but encourage those who only do men's sexual health to expand their knowledge base. They can learn how to operate with robots. They can learn new lasers. They can learn new formulations of testosterone. They don't want to learn how to examine a vulva. They don't want to learn how to talk to a female patient about sexual health. They think, oh, that's for the lady doctors or that's for the non-surgeons to do. So we have a challenge of who actually wants to do this work. Yeah, there aren't that many people, I think, unfortunately. And so that's why I'm investing in the young generation. I have hundreds of medical students, hundreds of pre-meds that are just really galvanizing and organizing. And we have published incredible papers on curriculum development, on clitoral adhesions. We coined a new term called the genitourinary syndrome of lactation last year, which is fabulous. And so we're doing really cool.
Tell us about that briefly.
Yeah. So we just coined, so what I just talked about a few minutes ago about the genital and urinary syndrome of menopause, or GSM. Well, the problem with the term, so GSM, many of you know as vulvovaginal atrophy, or even worse, atrophic vaginitis. These are horrible terms that are no longer relevant. And in 2014, they changed the name, thank goodness, to genitourinary syndrome of menopause. So that includes the frequency, the urgency, the UTIs. In fact, because we're loud on social media, the American Urologic Association is hopefully going to be publishing guidelines this year on GSM, which we have worked very hard on, and I can't wait to see the final publication come out. But they missed something there, because it's not just genitourinary syndrome of menopause. It's genitourinary syndrome of any hormonal fluctuation. So lactating women, right, have menopausal levels of hormones. And so because their sex hormones are low, they're going to get frequency and urgency, urinary tract infections, low libido, low lubrication, pain with sex, but nobody ever coined the term. So we call it GSL, genitourinary syndrome of lactation. But we also see there's a very high propensity of transgender males who have a lot of pelvic pain and GSM-like symptoms because of the too much testosterone and not enough estrogen. And so it's not just low hormones. It's a hormonal almost a dysbiosis. It's not the right word, but right, like a hormonal problem. And so we are looking in, if we don't have terms for these things, we can't study them. And so there's a brilliant medical student who's really taken on this research. And when I told her, it's incredible. She's a first-year medical student. And we started with just coining the terminology. We had that paper published. We just submitted a whole systematic review, and we're waiting to hear back from the journal. And I said to her, I sat down with her, I said, we're going to take this term, but we're not going to just write one paper. We have to go big. We have to let everyone in the world know that this term exists. We have to partner with large OBGYN practices to start studying it we can't just say this is a problem. We have to have a solution. We have to prove to people that vaginal estrogen is safe in lactating people. It's already been proven, but we have to do it on larger scales. And it's not just about writing the papers. We've had female Viagra since the 1970s. The papers have been written. It was in the New England Journal of Medicine in the 1990s. We have a marketing problem. And so part of this is getting these students to realize that we have to get loud. We have to advocate. And that's what gets new guidelines written. That's what gets guidelines changed. That's what gets better research with smarter people. This is why I do podcasts, because there are millions of people who need to hear this, who are going to say, oh, well, I have the research lab that could do this in 2 seconds, right? Or someone listening saying, oh, I work at the FDA. I can take that box labeling off tomorrow. That's what's going to change the world, right? In addition to the papers and the research and the clinical questions that we see in the exam room every day.
Absolutely. Absolutely. Well, you've mentioned something, and it's like I have this immense pressure that I want to ask these questions, but I'm told nowadays you can't say this. Apparently, there's a whole new lexicon that I have to learn. Dead naming. That was something I learned recently. Dead naming someone, that's using a name that someone used to use but no longer use. I was not too long ago approached. I was serving as a non-executive director on an organization. And they wrote to me and said, when you're using the corporate email address, you have to have your pronouns. And we noticed, Jonathan, you haven't added your pronouns. And I said to the guy, call me. And I said, I'm not doing it. I said, I'm not doing it. I have gay friends. One of the best weddings I ever went to was a gay wedding. And it was wonderful in Toronto. Amazing party. They're lovely people. I got no problem with that, but I got a problem with the politics that are being imposed on this discussion. And I know this is a bit provocative, but I think you may have some ideas on it, or some thoughts, certainly. So we talk about gender reassignment, okay? There are people who are biologically or genetically somewhere in between, intersex, Turner's syndrome, Klinefelter's syndrome, things like questionable genitalia at birth. And I've certainly seen 1 or 2 patients over the years. But politics have been imposed on the whole topic. And the people at the center of these debates, the patients, must absolutely get compassionate and evidence-based care. And I'm deeply concerned that there are genetic males and I'm not being pejorative, I'm really not. But what I do not want to see happen is people who are XY having their testicles, being effectively castrated, having breast implants, being given hormones, and then alternatively, genetic females having major surgery, and receiving doses of hormones. And no one has been able to tell me, to my satisfaction, what is the incidence of breast cancer in genetic males who go through these changes? What is the incidence of cardiovascular disease in genetic females who go through these trans changes? And how does someone with your specialty, you've forgotten more about it than I'll ever know, have at it, take it in any direction you want?
Well, this is a very large topic that you and I are not going to solve today. But what I would say is there is data, and actually some of that data really truly helps us in our informed care for menopausal women as well as cisgendered men, because hormones are not binary. Testosterone is not a male hormone. Estrogen is not a female hormone. And so here's a fascinating topic. I use testosterone therapy in my female patients at physiologic doses a lot. I just told you a story about a woman whose orgasm came back. And I now have data, right? So when we think about the scariness, we know that the testosterone is approved in Australia. So in the United States, it's not. There's no FDA approved testosterone for women, but it's approved in Australia. And when we think of a trans male who use 10 times, right, super physiologic doses of testosterone, and we have data for decades and decades, right? And so you actually see some safety data. So then when I give it to my cisgender women, I'm like, well, we have data, right? We have data that it's safe to use these hormones during surgery. It's safe to use these, there's no blood clot risk. That we don't see a cancer risk. And so very few medications can you say I've given 10 or I've seen 10 times the dose given. Now, it's also really important when we're talking about gender-affirming care, and whatever that means for you hearing it, but if I have a man who comes to see me, and we have very different guidelines on this. So as a urologist, I am much more aggressive. I am way more aggressive than my endocrinology colleagues, and my guidelines are more aggressive. But I'm a sex doctor. I care deeply about people's sexual health and their quality of life. So if I have a guy who comes to see me and he's 62 and his testosterone is 260 and he's fallen asleep at dinner and he's got erectile dysfunction, his libido's crap, and we give him testosterone therapy and we get him a sleep study and we look at his cardiovascular risk factors. We do all of those things. But when we give him evidence-based, guideline-driven testosterone, gender-affirming therapy, if you will, guess what? He feels great. His energy is up. His erections are back. His libido is back. I've never gotten hugs the way that I get hugs from the wives, from the husband. I mean, people are thrilled, right?
Yeah.
And so when it comes to us being when it comes to us having opinions about very detailed, like this is again the problem. Women are being denied hormone therapy. I was at dinner the other night, beautiful dinner party, and there was a neurosurgeon sitting next to me. And he said, and I'm talking about what I do, and I was telling them, and the neurosurgeon said, I tell women they must go off their hormone replacement therapy because they could get a meningioma. And I said to him, what's the data on meningioma? And I don't know, I actually need to look at the data. And he said, well, Depo-Provera can cause meningiomas. I said, Depo-Provera is not hormone replacement therapy. It has nothing to do with hormone replacement therapy. So how can you tell women they can't take, you're confidently saying that women can't have this, but you don't actually know the data. And he said, yeah, the data's probably crap. And I said, well, what about the lady who has a hip fracture, wakes up to pee in the middle of the night, gets a brain bleed, and you get called in the middle of the night? Maybe she should have taken hormone therapy to not have a hip fracture and to not have urination in the middle of the night. Like risk benefit here, guy. And these, so here he is talking confidently about a subject that he knows nothing about, that he should know more about, but he knows nothing about. And he's telling me why my field of work is meaningless because someone could get a meningioma. I feel that I am not one to speak fully on the transgender discussion. I am not a fellowship trained, a transgender specialist. That being said, I help a lot of all genders with their sexual health concerns. And so when someone comes and says, I my orgasm is important to me, and this is, and they may take more aggressive treatment than someone who couldn't care less. But we make decisions for people. Well, you can't have this because you could get breast cancer. You
Yeah.
can't do this. We actually don't do that to men. Your friend didn't get his prostate taken out because he wanted his erections. He deeply cared about them. Whereas that surgeon might have said, you're taking a deep risk. And we don't do so. So I will pause and just say, I think there's so much nuance here, and the data, there is data. There actually is quite a bit of data. And I think a lot of this data actually does help us when it comes to our cisgendered male and female patients. And so I don't know if that answers your question, but
Yeah, I mean, look, it starts the dialogue. And again, to be clear, my position is I care deeply about human beings. I care, and like you, I've always enjoyed learning who my patients are as people. My concern is that when there is an opportunity, especially in a profit-based healthcare system, when there's an opportunity to do things that, and I practiced in America many years, and I had private practice and as well as academics, and I understand it, but we've got to do the very best for our patients, not be paternalistic, not, be autocratic, work with them to reach a diagnosis and a treatment paradigm. But I'm just very concerned. There's been a bit of a moratorium on this issue over here, and they've stopped doing a lot of this care because they said we don't have certain of the data. And, there's been some concerns about the impact for patients for everything from urinary tract infections to psychological issues, social issues. And we've got to do the right thing for our patients. We have a huge moral responsibility, right?
and we've gotten it wrong many, many, many
Yeah,
times.
we have.
Right?
God
Right.
knows.
I always tell my patients when they get frustrated that we don't have more precise understanding. We see some very complex issues like connective tissue disorders and chronic pelvic pain and really significant medical problems that are really under looked at and under researched, underfunded. And my patients get frustrated and I get frustrated. And I tell them, I like to think back to, many, the 1800s, you could be the richest Rockefeller in town and you were getting leeches and bloodletting, and that it didn't matter. You had all the money in the world, all the technology in the world, and you got leeches and bloodletting. And we have screwed up as medicine. We have screwed up over and over and over again. And we've learned as we've gone. And so it's not perfect. There is an art here, and there's going, the more pull, you need the pioneers and the cowboys. You need the people doing crazy things. And then you need the smart people studying it in very systematic ways. And that's how we push guidelines ahead. Even watching the guidelines, even from when I got out of training, and I don't have as much gray hair as you do, but even when I got out of my
Thank you
training,
for that.
you're welcome. I had to do a little bit there. No, I've seen the guidelines change, right? I've seen the menopause guidelines change from lowest dose, shortest amount of time possible to truly a shared decision-making model, which I would like even to go evolve even more from that. So it's not set in stone. It really is an evolution, and it takes curious people poking at what is the standard of care and saying there's a whole population we're not even acknowledging, we're not treating, we're not listening to. So when you have 10-minute visits, what are you missing? You're missing a whole damn lot, right? Like you are missing so much.
And I would suggest that those 10-minute visits, you don't solve the problem. The patient comes back. It actually costs more money and takes more time. Do the right thing for the patient every time and you win. I think you're a superstar. I've got one final question. Well, actually, I've got 500 questions for you, Rachel. I could go on all day. But for today, one final question. Just imagine you come across a magical genie and they grant you 3 wishes for sexual medicine healthcare. What might those wishes be?
Super easy. It's what my pillars of what I care about is research, education, and advocacy. We need more research. We need more, like so much more research. It's crazy. We are 30 years behind on the female side compared to the male sexual medicine side. And we're not that far on the male sexual medicine side. Our research is crap. We need smart people who deeply care about this field, and we need collaboration. So please reach out if you want to collaborate, because we've got hungry medical students who want to work and learn more. Research, education. We must get this education into the hands of the people who need it, which is everybody. Everyone needs to know this stuff and care enough about their patients to talk about this stuff. stuff. And advocacy. We need to get the word out to patients that it's okay to want good erections. It's okay to want to be able to orgasm. It's okay to want to learn how to communicate with your partner. And if we invested in any of these things, I think the world would be a very different place than it is right now.
I think you're bang on target. And I think if there's anyone out there to get those jobs done, it's Dr. Rachel Rubin, my wonderful guest for today. Thank you so much for joining me, Rachel. It was an utter delight.
Thank you for having me.
So, folks, if this doesn't encourage you to subscribe wherever you get your podcasts, I do not know what will. Also, check out the archives. There's loads of great conversations. I'm such a lucky guy. This is the best part of my day, talking to clever people. And please join us next week. There'll be another fascinating episode. Until then, I'm Dr. Jonathan Sackier. I thank you for listening to the EMJ podcast. Please, everyone, stay safe, stay well, stay very, very curious. Bye for now.